is going to be co-presenting with me. So let me share my screen. One second, we'll get the right slide up. Can you see the screen all right, Aisha? Is it full screen? I'm going to assume it is, unless I hear otherwise.
Yeah, that's fine.
Thanks, Aisha. Brilliant. So what we're going to talk about today is our UCL Partners Proactive Care Framework for Heart Failure, which we launched last month. And what I want to talk you through first is our proactive care framework approach, because heart failure is one of a series of packages that we've brought together to support general practice in the delivery of long-term conditions care. And it really was came out of the challenges we faced as a result of COVID, but also addresses a number of historical challenges that we've got with long-term condition management in primary care. So we know that we haven't got optimal care for our patients with long-term conditions, late diagnosis, so we need to detect earlier, often suboptimal treatment, and quite significant variation in the way patients are treated across the country, across ICBs, PCNs, and across GP practices. In general, we often have a lack of self-management support for patients, so opportunities for them to get behavioural change support, and it's often very difficult in primary care to really give full holistic care. Primary care is also facing a number of challenges in terms of the increasing complexity of the patients, multimorbidity, and heart failure is a great example of that. You don't really get heart failure in isolation. Heart failure patients will have other comorbidities, and you're often balancing the management of those alongside the optimal management of the heart failure. And there's obviously time pressures. We've seen increasing demand, particularly post-COVID, and the priorities are often shifting as a result of national directives as well as local directives. And every year we expect the pressure of winter pressures, although the sort of workload we've been managing in the last year, we've had winter pressures all through summer as well. And then the pandemic has added to all that. We've seen quite significant disruption of routine care in our long-term conditions patients, which obviously will ultimately result in poorer outcomes for patients and will drive up health inequalities. And as I've said already, COVID has been increasing the healthcare demand and pushing more patients through the doors of GP practices and also hospitals. So we have a number of frameworks for cardiovascular conditions, and heart failure is an add-on to those. And they really work on the basis of stratifying and prioritising patients. And what we have developed is comprehensive search tools, which are built for EMIS and System 1. And they help us identify the highest risk cohorts of patients within each of the disease registers that we're focusing on. So if you look at AF, blood pressure and cholesterol, with AF, we look at those patients who aren't anticoagulated, those who are on combinations of anticoagulants and antiplatelets because of the bleeding risk, those that are on warfarin, because NICE now recommends we should be considering DOAC as a first-line agent, and those that might need renal follow-up, calculation of creatinine clearance and confirmation of the dose. So opportunities to prioritise those cohorts within the system. For blood pressure, really, we stratify based on the last recorded blood pressure in the patient's notes, and also identify those patients who haven't had a blood pressure in the last 18 months. And for cholesterol, those patients with cardiovascular disease who aren't on lipid-lowering therapy or suboptimal statin therapy, or who aren't achieving the target as now outlined by QOF. What we want to do in the frameworks is identify what needs to be delivered by a prescribing clinician and how we can support our patients better and systematically in terms of education, self-management and behaviour change. And there's a great opportunity for our R's role, so our health and wellbeing coaches, our social prescribers, to pick up some of that work and to really support patients in terms of their own self-management and behaviour change. And then the prescribing clinician can obviously focus on those that have the greatest clinical priority and the greatest risk, and also look at addressing multiple risk factors across these patients. So although we start with a search that identifies a patient as being in a single high risk cohort, the packages, the frameworks ensure that patients are dealt with in terms of their global cardiovascular risk as well. So what we've seen with these frameworks, these proactive care frameworks, is that they have been very well received in primary care, and we've seen significant national uptake. What we wanted to produce is pretty comprehensive packs for primary care so that people didn't need to duplicate all that work locally. And we've seen quite wide adoption, over 18,000 downloads of the search tools, which is around 3 per GP practice in the country. It isn't all me sitting in my office downloading the search tools. And also some recognition through GP awards and Innovate awards. And the blood pressure, the hypertension framework has particularly been adopted through the National Blood Pressure Programme, which was delivered by what used to be called the Academic Health Science Networks, now called Health Innovation Networks. And the aim of this programme was really to help recover the blood pressure control position post-COVID, because hypertension was particularly badly hit by COVID, with a huge reduction in the number of blood pressure checks that were undertaken and a drop off in the measured level of control. And as a result, all 15 of the academic health science networks were implementing the frameworks across their geographies, but focusing particularly on health inequalities. And what we saw as a result of this is over 600 primary care networks in England adopting that framework. And what we hope, of course, is because we use the same format for each framework, it's easy for people to adopt cholesterol, AF, and now hopefully heart failure. So why are we focusing on heart failure? So this is, I guess, the fourth of our cardiovascular proactive care frameworks, and heart failure is particularly challenging. At the moment, we have around 600,000 people with a diagnosis of heart failure, and we see an additional 60,000 new cases annually. But there are around 300,000 that are undiagnosed. And one of the challenges of diagnosis is that the symptoms are not specific to heart failure. They're very general and generic, and that often results in delays in making a diagnosis. It's also, heart failure is associated with significant mortality and morbidity. So about 1 in 5 patients will die within the first year of diagnosis. It is the most common cause of hospital admission in patients who are over 65 years. And it is also associated with a long length of hospital stay and a 30% risk of readmission within 3 months. So it's a huge burden for the patient, a huge burden for the family, and also a huge burden for the NHS. But we do have great treatments. We know that diuretic therapy can improve the quality of life for people with heart failure. And we have a huge number of drugs now that can improve mortality and morbidity, particularly in patients who have heart failure with reduced ejection fraction, where mortality in particular are significantly reduced with optimization of key drugs. So your ACE inhibitors, your ARBs, your ARNIs, and beta blockers, mineral receptor antagonists, and SGLT2 inhibitors, all demonstrating improved outcomes for patients. And we also now starting to see at least one drug improving the prognosis of patients with heart failure with preserved ejection fraction and mildly reduced ejection fraction, the SGLT2 inhibitors. So a big shift, actually, because until very recently we had very little to offer patients with HFpEF and HFmrEF. And you might be confused by that terminology, because we have seen a big shift in the way we categorise heart failure over the past few years. And that categorisation now is critical, because it determines how we go on to manage these patients. And part of the pack really focuses on the importance of that element of understanding the type of heart failure you're dealing with, and therefore particularly what prognostic therapies you should be offering. And so we have taken a slightly different approach with the heart failure pack. We still want to look at data, but what we think we need to do is actually systematically review the heart failure register so that every patient gets a full comprehensive review and embed that every 6 months in line with NICE guidance. So rather than do searches on EMIS and System 1, we think the most sensible approach is systematic desktop review of the heart failure register, ensuring the coding is correct so the diagnostics are clear and therefore the prognostic meds are clear. We obviously provide lots of resources to ensure that patients are optimised in terms of real world management, and then opportunities to use that wider primary care team, particularly the ARS roles, around structured support for education, self-management and behaviour change. So the average practice may have 30 or 40 or 50 patients with heart failure. So we're not talking big numbers like we did with hypertension, where we've potentially got 1,000+ patients to work through, and that prioritisation was really important. With heart failure, it's small numbers of patients, usually quite complex patients with multiple comorbidities, and very hard using searches to particularly identify those at greatest risk, which is why we decided to take this more systematic approach. So this is our stepwise approach to optimising care. As I've said, the aim is to be systematic in how we assess these patients and manage them, and to embed a proactive approach into routine clinical practice. NICE recommends that people with heart failure are reviewed at least once every 6 months. I know the QOF says annually. If we aim for 6 monthly, we might at least make sure we are achieving the annual reviews. And rather than try to have risk stratification searches, we think the easiest way to ensure we get these 6-month reviews is to take your register. It's 30 patients, divide it by 6. You need to review 5 patients every month so that they're all covered in the 6-month period, and really embed that systematic approach. So first of all, reviewing the diagnosis and ensuring correct coding. Many heart failure patients have very generic heart failure codes, and that doesn't tell you how to optimise those patients. So first of all, a desktop review, check what the diagnosis is, make sure they're correctly coded, comprehensive clinical review, optimisation of medicines, addressing comorbidities and risk factors, and then supporting patients with education, self-management and behaviour change, and embedding that 6-monthly process of ensuring a further comprehensive review following those steps from 2 to 5 again. Can I just ask you to make sure you are muted? There's a little bit of background noise. I think I may have managed to do that. The reason being proactive with heart failure patients is particularly important is because patients have repeated decompensation of their heart failure during the course of their clinical journey. And after each decompensation, in general, they don't get back to where they physically were beforehand. So we really need to optimise as early as we can and keep on top of these patients to prevent as many of the decompensations as possible, and ensure that they may maintain their healthy life years for as long as they possibly can. So you saw a generic slide for our cardiovascular frameworks. This is our overarching slide for the heart failure framework. We need to ensure all our patients are identified as having heart failure with reduced ejection fraction, those with mildly reduced ejection fraction, and those with preserved ejection fraction. So there's a desktop process, which we'll look at in a minute, that goes through that. Because of these small numbers and the way in which we code patients, quite hard to search for those that we might want to prioritise. So we may want to prioritise those who are newly diagnosed in the last 6 months, had a hospital admission in the last 6 months, who we can identify that the prognostic medication isn't optimised, and those that have a heart failure diagnosis with complex comorbidities. So as we're reviewing the coding, we can identify those that we might want to prioritise for earlier review, within the boundaries of accepting that we need to review all these patients every 6 months. The ARS roles can support these patients in terms of gathering all the information we need for clinical review, so bloods, blood pressure, pulse rate and rhythm, ensure there's a recent ECG, their weight, their smoking status, any symptoms, for example, support with self-management, particularly things like recognising worsening heart failure and daily weights, and signposting to educational resources, and then supporting patients with those lifestyle interventions that we want to encourage: smoking cessation, weight loss, improved diet, increased physical activity and moderating alcohol. Similar for all of these patients, while the prescribing clinician can then focus on optimising the meds that will improve quality of life and also their prognostic meds for the long run, supporting patients to adhere to drug therapy, looking at other cardiovascular risk factors like high blood pressure or lipids, and identifying if the patient has any underlying AF, for example. So as I said, critical to understanding how to manage heart failure is understanding the diagnosis. And we have 3 types of heart failure that we need to understand the diagnostic criteria for. So all of them will have the signs and symptoms of heart failure, and all of them are likely to have a raised NT-proBNP. NT-proBNP is a blood test that we usually do in primary care to identify if the patient is likely to have heart failure or not. It's essentially a rule out. If NT-proBNP is normal, it's unlikely they have heart failure, and you should be looking for other causes for the symptoms. If NT-proBNP is high, they may have heart failure, and then they need to go on to the next step in the diagnostic pathway. So in this case, it would be an echo. So for heart failure with a reduced ejection fraction, patients need to have signs and symptoms of heart failure. They would have a raised NT-proBNP, and on the echo, they would have an ejection fraction less than or equal to 40%. This is the sort of traditional heart failure that we've thought about and worried about for the past 20 or 30 years, heart failure with reduced left ventricular systolic function. And we have a lot of prognostic meds for this cohort. So the ACE, ARBs, ARNIs, beta blockers, mineral receptor corticoid antagonists and SGLT2 inhibitors. Obviously need to look at their symptoms, lifestyle and other risk factors. So that's our sort of traditional heart failure patient, but there's always been other patients with heart failure symptoms that don't necessarily have a reduced ejection fraction. And they are now defined as heart failure with mildly reduced ejection fraction. Again, symptoms will be there. NT-proBNP will be raised, and the ejection fraction sits between 41 and 49%. In this cohort, really, we've got SGLT2 inhibitors as a proven prognostic medicine. Some clinicians, specialists, would also consider them suitable for HFrEF treatments, although the evidence base is not as clear there. And then the final cohort is heart failure with preserved ejection fraction. Again, signs and symptoms, NT-proBNP is raised. They would have an ejection fraction of more than 50%, but they also have structural heart disease. And that's important because otherwise all of us would have HFpEF. You know, hopefully my ejection fraction is more than 50%, but I don't have structural heart disease. So there has to be something else to give the heart failure diagnosis. And again, for these patients, really, we're talking SGLT2 inhibitors, as well as all the other interventions. And some heart failure specialists are using mineralocorticoid receptor antagonists, spironolactone and eplerenone in that cohort. So 3 different cohorts. These cohorts are going to become more and more important because there are more and more trials going on looking at the impact of different drugs in different cohorts. And it is going to be important in future that you can identify your HFpEF population as new drugs get licensed for that particular cohort. So we pulled together a little algorithm about how you might identify what type of heart failure the patient has and make sure they are coded correctly. So there are codes for HFrEF, HFmarEF and HFpEF that are recognised by QOF. But for QOF, in those with reduced ejection fraction, you also need a code for LVSD, which helps drop the patients into the right bits of QOF for ACE, ARB and beta blockers. So really important that you do get the coding correct so that you don't miss out on any of your QOF points. A lot of patients will just have a very generic heart failure code at the top of this algorithm that doesn't define the type of heart failure they have in the detail we need in order to know that we are treating the patients with optimum medicines for their particular diagnosis. And we've got a bit of a more detailed list of things you might want to check to find these out. In many cases, there'll be letters, echo results, letters from the specialist team or from the community heart failure team. But if that isn't clear, you might actually need to go back to the local heart failure team to see if there has been a formal diagnosis made, and if not, go down the diagnostic route with NT-proBNP and or an echo, because it is critical that we get these diagnoses correct. So at this point, I am meant to be handing over to Paul Wright, but I have no idea whether Paul is in the room. Is Paul in the room, Aisha, do you know? If not, I will press on.
I haven't seen him come through.
He is out and about in the depths of Stratford and maybe struggling to get online. So I'm going to keep pressing on. I'm sure he will join us for questions if he can't join us for the actual presentation. And so in terms of management, what we try to do is build a sort of systematic approach to how you might approach reviewing these patients clinically. And the first step, as we've said, is knowing what type of heart failure you're managing, making sure that's correctly coded, and then looking at a comprehensive clinical review. So NICE defines this as an assessment of functional capacity, their fluid status, their cardiac rhythm. That might not require an ECG, it might be simple pulse check for some patients, but that's the minimum. Assessment of their frailty, their cognitive status, their nutritional status, mental health, and general well-being. So a comprehensive review of the patient's clinical status. We also need to look at bloods. So that would include for pretty much every patient renal function, serum potassium, sodium levels, LFTs. For specific patients, depending on where they are in the pathway, whether they've got comorbidities, you might be checking HbA1c to either exclude diabetes or to monitor their progress with their diabetes. Thyroid function tests, that's an issue, the full blood count and serum ferritin. Next step will be to, and you can see that these underlined bits in the pack will take you to a separate page that will take you through that monitoring, how often to do it, and a bit more detail. Then reviewing medicines. Our first step is usually to look at how well symptoms are controlled and look at diuretic dosing in order to ensure the patient is sufficiently offloaded. But in order to do that, we also need to make sure we're doing that safely, checking renal function, serum potassium, serum sodium, etc. We want to optimize the prognostic medicines. So for HFrEF, that's your ACE, your ARB, or your ARNI, which ARNI is sacubitril valsartan, if people don't recognise that abbreviation. Optimize the beta blocker. If symptoms continue, NICE recommend adding an MRA. And for all types of heart failure now, SGLT2 inhibitors are recommended. Those that have type 2 diabetes, we obviously need to think about their blood glucose control and think about the addition of or switch to SGLT2 inhibitors. It should be part of the management of all the patients with type 2 diabetes and heart failure. Think about other cardiovascular risk factors. We have proactive care frameworks for AF, high blood pressure and lipids, also diabetes, so raised blood glucose. So you can link through to those. And then support in terms of education of the patient around their condition and their risk factors, self-management and behaviour change, and lots of resources around doing daily weights, self-managing diuretics, lifestyle risk factors, supporting patients to measure their blood pressure at home, and other digital tools that may be useful. We've got some guidance on when to refer. And obviously the last step in all of this is making sure they're scheduled for the next 6-monthly review, or if you need to follow them up because you've changed their medicines, it might be review again in the next 4 to 6 weeks. So we've got an algorithm for managing heart failure with reduced ejection fraction. So these are patients whose left ventricular ejection fraction is less than 40%, optimizing ACE and beta blocker first, adding an MRA if they're symptomatic, and then thinking about more specialist interventions, which could include ARNIs, so sacubitril, valsartan, or SGLT2 inhibitors. And a very similar but short algorithm for patients with HFpEF, so preserved ejection fraction or mildly reduced ejection fraction, where it's optimizing the diuretics for symptom control, SGLT2 inhibitors, because we know the outcome, the prognostic benefits are there for these cohorts, and then 6-monthly reviews. As I said, we have packs already for blood pressure, so hypertension, AF, diabetes, and guidance on lipid management for patients with or without cardiovascular disease. So links across to those packs and the sort of key priorities for patients with heart failure, because sometimes we have a slightly different approach. For example, in AF, we don't necessarily restrict the rate as much as we might have done. Obviously, we need to anticoagulate if the patient has a CHA2DS2-VASc score that warrants that. For hypertension, obviously, we're using ACEs and beta blockers as core heart failure drugs. You may then consider other drugs like amlodipine, which we know are safe in patients that have heart failure due to left ventricular systolic dysfunction. Difficult with these heart failure patients sometimes to know when you need to seek further advice. There are some patients that will need urgent specialist review if they are very symptomatic, so NYHA class 4. If they've had a significant increase in their shortness of breath, increase in levels of fatigue, chest pain, or syncope, they would need more urgent specialist review. The middle ground are patients who are symptomatic with NYHA class 2 or 3 who have been optimized on the core drugs, which might be ACE, ARB, ARNI, beta blocker, MRA, and SGLT2, so may need further intervention. That might be drug therapy, or it might be cardiac device therapy. And patients that are sort of showing they're going in the wrong direction, so increasing weight, increasing shortness of breath, increasing fluid retention, not at the point of acute crisis, not responding to increased doses of diuretics, but an opportunity if we can get them seen relatively quickly to avoid decompensation and hospitalisation. And then the rest of the cohort hopefully will be patients who are stable with no or very minimal symptoms and optimised on their prognostic meds. And some of this might be done virtually over the long term, although many heart failure patients will need to be and will want to be seen face to face because of their complexity. So, an important element of all of our proactive care frameworks is the support we can offer patients from the wider team. That could be anyone from healthcare assistant, health and wellbeing coach, a link worker, a social prescriber. It might be your physician's associates or nursing associates. All of these individuals can support patients with education, lifestyle and behaviour change. So what we've developed are support tools and resources for these individuals working in practices to support patients. And for education, it might be, well, what is heart failure? Why do I need to do daily weights? What is high blood pressure? What's cholesterol? And then the sort of self-management piece, how to check your blood pressure at home, how to choose a blood pressure monitor if they're going to buy one, when they need to seek advice from the GP practice or even from the community heart failure team if they've got access to one, and then behaviour change interventions, so healthy eating, physical activity, smoking, cessation and alcohol, for example. And lots of resources. So rather than you having to go off and look at the British Heart Foundation, Pumping Marvellous, which is a patient support group for people, specifically with people for people with heart failure, we've drawn a lot of the resources together in one place so you can easily link to them. So in particular, I think important is the daily weight charts, getting patients to weigh themselves when they wake up in the morning, after they've been to the toilet, before they get dressed, to see if there's any significant shifts, because you don't put weight on overnight, but you do put fluid on overnight. And if people are taking in half a kilo of fluid every day over 3 days, there's a sign that we might need to adjust their diuretics before they get symptomatic. So huge amounts of support for patients, by patients and from patients, as well as from the patient support organisations. And then the wider resources that might be relevant can be tailored to the individual patient. High blood pressure, lipids, reducing your blood pressure, measuring your blood pressure, and then general behaviour change advice of healthy living, essentially. To support these discussions, often, as I say, delivered by R's roles, we've developed a sort of script or a guide that takes people through these individual cardiovascular risk factors to make sure the right questions are asked, any red flags are identified, and the patients get consistent messages and the right support. So this is to support people as they start up in these conversations. As they become more and more skilled and confident and competent, they may well not need to refer to the guide anymore, but it just means there's a sort of comprehensive framework for them in structuring the conversations, and that nothing gets omitted or missed out. And then finally, we have some very detailed advice about how to manage medicines in heart failure. These patients often have relatively low blood pressure, renal function's not great, and there are challenges in optimising the ACE inhibitors, for example, and the beta blockers if the blood pressure's low or the heart rate's a little bit low. So we have a sheet, an individual sheet, lots of detail about how to manage diuretics in heart failure, how to up titrate, down titrate, what to monitor, what to worry about and what not to worry about, because we do accept lower blood pressures, worsening renal function, more in heart failure patients, because often they need these drugs to have any reasonable decent quality of life. So it's a real balance. So we try to give you that detail, information about optimizing the drugs. Diuretics obviously really about symptom control. You'll need more diuretics in winter when it's cold now, and less in summer when it's hot. People sweat off their fluid and need less diuretic, and often start to show signs of renal decline if their diuretics aren't appropriately adjusted in relation to things as simple as the weather. We have a particular problem at the moment, for those that are aware, that with bumetanide supplies. So lots of places have recommendations about moving people from bumetanide to frusemide. We've got the equivalent doses on this sheet, but just something to be aware of, that if you have heart failure patients on bumetanide, they may well need to be moved to frusemide, and their weight should be monitored to make sure they respond effectively to that. And I put one example of a prognostic med. So this is ACE and ARBs. So we routinely would use ACE inhibitors first line in heart failure, moving to an ARB, a sartan, if the patient couldn't tolerate an ACE inhibitor. Aim for these drugs is to get to the optimal doses used in studies. So for ramipril, 5 mg twice a day. For lisinopril, it was 35 mg daily. And for enalapril, which we don't use very often, 20 mg twice a day. Similar optimal doses with the sartans. We are limited sometimes in terms of how we can increase the doses due to reductions in renal function, high potassiums, for example, as well, and also blood pressure. So advice on how to deal with those issues should they occur. So we've got the ACE-ARBs, we've got a sheet for beta blockers, mineralocorticoid receptor antagonists, spironolactone and eplerenone to the rest of us. We've got SGLT2s, sacubitril, valsartan, and each of those, some of the challenges you'll face and how to deal with them. So that, in a nutshell, in 40 minutes or so, is the content of our heart failure pack. We try to make it as comprehensive as we can and give people the information they need to be able to really optimize both the medicines to improve quality of life, particularly the diuretics, but also those prognostic medicines that need to be initiated and dose titrated when patients are stable in order to protect them from decompensation. One just quick highlighting another opportunity. There is an interactive webinar next week, December the 6th, a workshop which will work through the how to implement, not specifically the heart failure framework, but the broader UCL Partners proactive care frameworks, talk you through some of the challenges and how they have been overcome in other areas. So if you're interested in that, do let us know. And if you want more information, you can find it through this email address, primarycare@uclpartners.com. All of the frameworks are on our UCL Partners website. All of the resources are free, including the UMIS and System 1 searches, and readily downloadable directly from the website. So I'm going to see now if there are any questions in the chat box, and hopefully Aisha will assist me with fielding questions.
Yeah, you've got quite a few questions that have come through. Some of them have actually been answered by other people, thankfully and helpfully. So you won't need to answer all of them. But the first one, I think you might have just mentioned it a bit about coding. So is there a system of coding or codes for patients with improved ejection fraction to look out for them as treatments vary in the different categories?
So once a patient has got heart failure with reduced ejection fraction, even if they improve, they remain coded as heart failure with reduced ejection fraction, because all of those drugs that you've started them on when they were in that category are the drugs that have led to the improvement in their ejection fraction. If you take those drugs away and treat them as a HFpEF, they will very rapidly deteriorate. So once coded as heart failure with reduced ejection fraction, patients stay in that cohort. The other two, obviously, HFpEF and HFmrEF, over time could deteriorate to heart failure with reduced ejection fraction as well, and might then warrant all those additional treatments. So they can move into the LVSD category, the reduced ejection fraction category, but people can't really move back the other way, as it were.
Thank you. And then there's a couple of questions here from Emma, which have been answered by Robin. So thank you for responding to those, Robin. And Emma, if you've got anything additional on that, please let us know. We also have a question from Ryan on should SGLT2 inhibitors only be added if symptomatic or for everyone?
Well, that's a bit of a debate that's going on in the heart failure community at the moment. If you look at the European guidance, they would say everyone with heart failure should get an SGLT2 regardless of symptoms. Currently, the NICE guidance says that you should optimize the ACE and the beta blocker and add an MRA. And if they're still symptomatic, that's where an SGLT2 inhibitor is recommended. But as I say, there is a bit of an ongoing debate, and NICE are currently reviewing the heart failure guidance, so there is a possibility that our UK guidance may change. The challenge, of course, is Europeans don't assess cost effectiveness, so there may be a benefit from these drugs, but it won't be as great as those that are symptomatic, and it might not be good use of our resources, which is the big challenge.
For the next one, I think you did address this, but just to ask this again. So please define optimize. Are we trying to titrate to maximum doses or stabilize observations?
Your aim should be to get to the doses that were used in the clinical studies. So, maximum dose of licensed dose of the ACE inhibitors or ARBs in most cases, and the beta blockers. So, for example, we use a lot of ramipril, so we'll be looking at 5 mg BD ramipril and 10 milligram of bisoprolol. We should keep titrating regardless of symptoms until they're on the maximum tolerated dose. And it's things like very low blood pressure that's symptomatic, or low heart rate that might obviously, or poor renal function that might limit how far up the dosing cascade you can get.
Great. And then we've got another question about how you'd advise optimizing treatment for patients currently under cardiology or heart failure clinic care. I tend to leave so as not to complicate or confuse matters. Is this the best approach?
I think if they're under the heart failure service, then they would be hopefully in an active optimization phase. The community heart failure nurses particularly spend a lot of time supporting patients with those ACE inhibitor, beta blocker, and other drug optimization during the first few weeks, particularly in months after a diagnosis. If they're only being seen once a year by a cardiologist as a sort of routine checkup, and you can see that they haven't necessarily been optimized, then those are the ones you might want to re-review and ensure that there is an active plan rather than a sort of very passive annual review going on.
Rachel's asking, why do we use twice daily Ramipril?
It's partly to do with the studies. They were designed with twice daily Ramipril. That's what the license is. And also probably because these patients tend to run lower blood pressures. So it's more likely they're going to tolerate 5 milligram in the morning and 5 at night than giving, 10 milligram once in the morning. There's a greater risk of a larger drop in their blood pressure and more dizziness, lightheadedness, etc. that might want them to might make them want them not to adhere.
I've got a question here from Alison asking, where do we start when we have a very late diagnosis, often missed in reality due to non-specific symptoms? How do we decide where to start in terms of treatment options, especially in the elderly?
So, well, first step, and it depends on your local service. For us, we have a one-stop heart failure service. So a new patient where the BNP was up, they'd go to a one-stop, get their echo and be reviewed by cardiology, and usually would go to a community team to get them started. If you've got patients that have been coded but not optimized historically, that need optimization, the first step really, and that is pretty clear in the pack, is the ACE and beta blocker. Those are the sort of core of heart failure therapy. Optimize the ACE as far as you can, beta blocker as far as you can, and if they're still symptomatic, we're looking at the mineralocorticoid receptor antagonists. But also see what your local community or hospital-based heart failure services, because they may well be able to support, particularly in those dose titration phases, particularly where patients are a little bit more frail or multiple comorbidities make it more difficult to optimize.
Yeah, Alison's just come back with it very late and towards the end stage.
Then you might be looking at palliative care, symptom control. You think it's this is about making people comfortable in the last stages of life, then heart failure patients should get the same access to palliative care as we traditionally think our cancer patients would be. In fact, heart failure has a worse prognosis than breast cancer or prostate cancer, so we should think of this as something that needs palliative care support in those end stages and keeping people as comfortable as possible.
So Ryan's asking, is there any guidance about titration? How quickly to titrate?
So we normally titrate, well, in each of the SPCs, particularly for the beta blockers, there's a titration schedule for each of the drugs. Normally talks about stepping up the dose every 1 or 2 weeks. With the beta blockers, the ACE inhibitors, we normally look at stepping up the dose every 2 to 4 weeks. But sometimes the dose titration can be very extended because patients' blood pressure is a bit low. When you up titrate a beta blocker, they can get a bit more breathless. So you end up having to delay the next step up, trying to maintain them on the current step, deal with the symptoms and step up. So it does have to be tailored to the individual patients. Some of our local clinics now are doing rapid up titration, bringing patients back much quicker, and really pushing up the doses. I think that's harder to do in primary care because one of capacity and patients being willing to appear before you to have that done. So I think you have to work with the individual patient to work out a schedule that works for them as well as for you.
So Victor's asking, are there heart failure searches on your website? I'm struggling to find it amongst the other searches. We don't have those, do we?
No, we haven't put together specific heart failure searches because every practice has a heart failure register. They're usually very small. you know, a matter of 30, 40 patients per practice, and therefore what we want to embed is a systematic process of going through that register rather than trying to identify individual cohorts that might be higher risk. So we just say go to your register and work through it systematically. And you'll identify as you go along patients that you think need to be brought in earlier and some that seem very stable and can be brought in towards the end of your sort of 6-month rolling programme. And once that's established, you shouldn't really need searches. These are all high risk patients and we should be reviewing them proactively and systematically.
Okay, and then I've got another question here about any heart failure specific guidance or reference on palliative end of life patients. You know, I don't think we do have at the moment, but there are guidelines out there for dealing with symptoms, heart failure symptoms at end of life and managing that palliative phase. So I will try to identify some and add to the pack some links to end of life care references. One of the particular problems for heart failure patients are those that have had devices put in, the implantable cardiac defibrillator, because there someone's already put one on. Excellent. Their defibrillators need to be switched off if they're at end of life, and often that process is quite tricky. You basically need a big magnet, but someone needs to provide the magnet and know when to put it on the patient. So those are the sorts of things specific to heart failure that it's worth knowing about, because you're trying to die, but you're constantly being shocked by an implanted defibrillator. It's not very pleasant for you or for your relatives. And someone's put in the chat an NHS England guide, so we will link that directly into our pack. Thanks, Lucy. That's the end of the questions, actually. So if there's any others, please feel free to put it in the chat, or if you want to unmute and ask Helen verbally, then that's fine too.
Just having a quick look to see if there's anything else I wanted to make a comment on. Someone's saying that they've got some searches which will help to identify unidentified heart failure patients, which is great. But the biggest challenge we've found, so we did a lot of systematic work in a couple of boroughs in southeast London, and we found that the biggest problem we had was the sort of generic coding of heart failure and the lack of detail as to when and how the diagnosis was made. So quite a lot of detective work working with our local community heart failure team to make sure that patients did have heart failure. We knew what type of heart failure and were coded correctly into the system, so we could then optimise the care.
Got a hand raised by Gillian.
Hi, good afternoon, Helen. Thank you very much for that talk, actually. My comment actually was about the SGLT2 inhibitors. As we know, recently they've been approved by NICE for use in patients with mildly reduced ejection fraction. So what I wanted to comment and say, I know there were some questions about when to initiate the SGLT2 inhibitors and whether or not, but potentially those patients with the mildly reduced ejection fraction could actually be on simply, I guess, a diuretic because of their symptoms. And in addition to that, we can now consider adding an SGLT2 inhibitor. So depending on your locality and what's been approved by your prescribing committee, it's actually possible for those patients to be on just those two medications.
Absolutely.
When we think about the SGLT2 inhibitors, improve within 14 days. There's evidence has shown that there is actually improvement in symptoms within 30 days. Again, you're reducing hospitality as well as mortality for those patients. So for me personally, I think we're really advocating to try as much as possible to consider those patients as well to improve quality of life.
By definition, all of those patients will be symptomatic, won't they?
That's correct.
Essentially, you've only got diuretics and they're not prognostic. So yeah, we will see an explosion, I think, of SGLT2 inhibitors for HEF and HFmrEF. I think the biggest challenge in doing that is that a lot of patients aren't coded. They're just heart failure, so you have to go through that process of identification.
Stephen?
Thanks. Hi there. Our local service, we've done this kind of structured care for years, which is helpful to understand that, you know, we've been doing it okay. But however, our local service used a broader definition, and they often started people on ACE and beta blockers whose ejection fraction was below 50%. So we've now got quite a lot of people who fall into that moderately reduced cohort who'll be on medications that, you know, I mean, pragmatically, I was thinking we leave them on because if they're stable and they're not having any problems, but it's just going forward, we wouldn't be starting people on those drugs potentially.
Yeah, I agreed, and you'll see if you look at our breakdown of the different types of heart failure that we have said a lot. Some of the specialists are using the core HFrEF drugs in the HFmrEF, the mildly reduced as well. And it'll be interesting to see if NICE comes out with a bit more of a clear ruling on that. The last NICE guidance we had didn't even recognise HFmrEF. It was either reduced ejection fraction or everything else. And then obviously now they've got these new drugs, especially SGLT2 inhibitors. They're having to recognise HFmrEF formally and make a decision as to where does the line get drawn around the other prognostic medicines. Clearly in the studies, the companies tend to recruit people who have poorer ejection fraction because it's easier to show the benefits, but there may be an advantage, as say some specialists are. We've left it fairly open in our pack at the moment because we don't really know which way NICE will land.
Okay, thank you.
Thanks, Helen.
Right.
Just to clarify then about the SGLT2, so Helen just asked in PEF and HFmrEF who are stable on diuretics and unsymptomatic, would you introduce SGLT2?
Say that again, sorry, I missed it because I was reading the chat box, getting distracted.
Right.
Say again, Aisha.
So let me just make sure I've not lost it. Yeah, in HEF, PEF and HFmrEF, who are stable on diuretics and unsymptomatic, would you introduce an SGLT2 inhibitor? And why does NICE specify symptomatic HEF, PEF, HFmrEF if diagnosis implies symptomatic? People are on different parts of their journey.
It's unlikely that diuresis alone is going to make a heart failure patient completely asymptomatic. It will happen occasionally. The symptomatic HFpEF and HFmrEF is really how they were defined in the studies. So the difficulty, as soon as you start asking patients about symptoms, there will be evidence of symptoms, you see what I mean? They'll either have some breathlessness, some exercise, lack of exercise tolerance, ankle swelling, you know, regardless of the diuretic therapy. So I suspect most patients with HFpEF and HFmrEF will qualify for treatment, potentially with an SGLT2. There are very few truly asymptomatic heart failure patients, if you ask about symptoms.
And a question on what typical percentage of HFrEF patients would you expect to see?
Well, it's very tricky because obviously we have been more systematically trying to find HFrEF for the past 30 years than the others, but certainly over half the patients should be HFrEF. Maybe between 60 and 70% of patients would be HFrEF. Those percentages may change over time, I guess, as we more systematically and clearly understand the other elements of diagnoses. But certainly well over half would be HFrEF. But if you look at our coding at the moment, it's well under half on the LVSD register, so that's where there's a big gap to be made up because it's potential those patients aren't on ACE, beta blocker and all the other prognostic meds.
And a comment from Gillian, the thing is in secondary care sometimes use the European Society Cardiology guidelines and primary care refers to NICE and hence disparity at times, so treatments and categories may vary.
Yeah, it is very tricky. ESC obviously tend to be a little bit further ahead in terms of the recommendations than NICE, but actually the robustness of the NICE process and the cost effectiveness rather than just looking at does this drug work or not work, I think is really important. If we expand our usage beyond the evidence base, then we potentially dilute the benefits and get less bang for our buck. So I think we have to be really careful about extrapolating and say, well, if this cohort benefits, they'll all benefit. And you know, NICE looking at it again, so hopefully we'll get an idea soon where they will land in terms of what their recommendations are.
Okay, that was the end of questions.
Excellent. Thank you, everyone. Thanks for joining us today. Do have a look at the framework on the website I'm going to add the link to the NHSE palliative care heart failure document that has been pasted in the chat. And do remember that next week there's another workshop looking at how you implement the proactive care frameworks in the real world of clinical practice in primary care. Thank you, everyone.
Thank you.
Thank you.